topic I'm going to discuss about is a very important topic. It's basically a simple art in surgery. And this is basically a building blocks of a major advanced GI surgery. And for any advanced GI surgery, you should be knowing about the gastrointestinal anastomosis. And with adequate supervision, and if you have a good sound foundations, even a training can produce some results which is comparable with established surgeries. GI anastomosis has a very long history. People started with anastomosis. They were very often, surgeons were very often. And every surgeon, they used to have their own techniques and they used to keep very fancy names to it. But with progress of time, with the increasing knowledge of physiology, anatomy, and healing, the anastomosis procedure became simplified and simplified. Nowadays, we usually do a single layer anastomosis, and even with the technical advancement, people are doing a stapler anastomosis. Even then, the era of intestinal anastomosis started around 300 years back by a British veterinary surgeon. This also reflects that why we should publish our findings, any cases why we should publish. 300 years back, a veterinary surgeon, a British veterinary surgeon, he published a report. What he did was, he was called for the obstruction, probably obstruction of the origin of an ox by a farmer. He opened the abdomen, he set a gangrenous bowel, he dissected the bowel, did the anastomosis over some form of stent. The ox passed stent after 1 or 2 days. Then that cattle that gradually improved. And so the era of GI anastomosis started. And that was the time when India was still governed by Mughals, and the Americans, they were still ruled by British and French. That was long back. Similarly, in 1727, there was a surgeon called Ramdor. He came across a young lady who came with a ruptured inguinal abscess. And on further examination, he found out it was a strangulated inguinal hernia and there was a gangrenous bowel. He resected the bowel and simply he invaginated the two ends with few simple sutures. And luckily the girl survived. Unfortunately and fortunately for the surgeon, the lady died after 2 years, and the people, they did autopsy and they found that the anastomosis was perfect. That was another milestone. So we had a very gradual evolution. The surgeons were fearful. They had a fear of opening the abdomen. They had a fear of opening the peritoneum. They think that when we open the abdomen, it causes peritonitis. But around 200 years back, a famous surgeon, Lambert, he proposed seromuscular suture in the valve. It was in 1826. That was the modern era of GI anastomosis. Then by 1990s, after the advent of antisepsis, anesthesia, GI surgery was progressive in lips and bones. There were many great surgeons like Langenbach, Hooker, Halstead, they all contributed. And in 1926, the vascular anastomosis was also introduced. Connell's introduced a popular technique, Connell's suturing, in 1963. And now the most popular current technique is the Matheson. It was published in 1975, where he proposed an extra-mucosal interrupted single layer anastomosis, and that's the now gold standard of a GI anastomosis. Now the question is, how often does it leak? The various reporters, various publics, they say it ranges from 1 to 24%. But there are many gray areas. There are many gray areas, and you also have many white areas. But if it leaks, it's a black for the surgeon and for the patient. Therefore, why should we care? Why should I care? Why, when it leaks, why should we care? Because leak leads to longer hospital stay. It increases the higher mortality. The patient has a higher readmissions, higher reoperations. Patient has a poor quality of life. There is a risk of distal recurrence, and patient has a delay in receiving adjuvant chemotherapy. Similarly, this leak is not going to disappear from our field. This issue will remain and will likely to persist in the foreseeable future as well. And when the leak occurs, it's very difficult to manage, and of course it's very frustrating to the surgeons. It's frustrating to the operating surgeons, into the resident interns, and all the team. There is a cloud of anxiety. So how can we achieve a good anastomosis? It's basically a three-pronged approach. You should have a good surgical anatomical knowledge. You should have a robust technical expertise and training. And of course, you should have a fine clinical judgment. These are the three pillars of a good anastomosis. It was, it is, and it will. And as I have already said, the intestinal healing, it mimics the wound healing elsewhere in the body. And we can divide it into three phases. It's the acute inflammatory phases, which lasts for around 7 days. Proliferative phase, which lasts for 3 weeks, 3 to 4 weeks. And the maturation phase, it goes on, mostly for months. These are the 4 layers of a bowel. And the most important one, with view of anastomosis, is the submucosa, because it provides the tensile strength. Unless I have some bowel facts. When you do anastomosis, the 60% of the strength, it reaches within 3 to 4 days. And by 100%, by 1 week, the tensile strength reaches to 100%. And the collagen is the utmost important, it's the most important protein for bodybuilding. As I have said, submucosa is the strongest layer, and visceral peritoneum, it greatly influences the healing. This is a human body, and this human body is in fact an aggregation of vascular spaces. It's a place of many areas where you have a low blood supply. And for good sound healing, as elsewhere, the bowel also need a good bowel supply. Good blood supply. And what are the tricks for good blood supply? When you are operating, always look for the vessels in the mesentery before choosing a resection site. Always ensure pink mucosa, bright red bleeding from the arterial vessels in the submucosa. Think always before cutting colon, and think blood supply to the colon is always precarious. And if you have any doubt, if you have any suspicion for a blood supply, always opt for side-to-side anastomosis if it's possible. And always avoid this dusky green, pink mucosa and dark ooze of venous back bleeding from the cut surface of the bowel before you embark in the journey of anastomosis. Nowadays, there are technologies are also helping surgeons, especially when surgeons are doing a laparoscopic surgery, they can inject a dye and go for an intraoperative fluorescence imaging. There are two systems, SPY system, Firefly system, which helps to delineate the vascular area in the bowel. And the studies have shown that around 5 to 40% change in the bowel length. Another important thing is you should always avoid tension while performing anastomosis. Because tension, as you know, it increases the danger, it causes disruption, and you should consider various factors that increases tension, like the tension may increase due to a post-operative swelling, due to the IBS, change in a body position, or even a bowel feeling. When it feels, the tension inside the bowel may increase, and that increases the risk of disruption. So, if you have a gout, always mobilize the yin without damaging a blood supply to decrease the tension between the two adjoining bowel. So the general rules are, this applies for all the surgery: good exposure, good mobilization, and a good dissection. That's the most important thing. Always, when you divide a mesentery, you should always be careful. Always clear the fat and appendix epiphyseal of the colon before doing anastomosis. When you tie, think always risk of slippage of the ligatures. Therefore, the careful placement of ties is very important, because when you slip in the mesentery, there may be a hematoma, and in the post-operative period, it may decrease the blood supply to the anastomosis site and threatening the bowel viability. Always minimize fecal contamination. So, always use bowel cams, isolate your playing field, and with use of ample packs and tetras. So, in general, how is different in different tissues? If you look at this table, small intestine is the safest one. The leak rate is very low, 1 to 3%, 1 to 4%. But when you go towards the proximal and distal intestine, the rate increases. In esophagus, it's around 10 to 14%. In a low rectum, it's around 13 to 19%. Always consider this fact before doing anastomosis. And there are many patient adjustable factors which plays role in anastomosis healing. And unfortunately for the surgeons and a whole medical team, this is a quite frustrating thing, because most of them are unalterable and unmodifiable. Even then, you have to think before doing anastomosis whether the patient is having a good supply or not. And if the patient has these factors, can you go for the proximal dry version, or rather than making a stoma, could we make a permanent stoma? You should think about this. If the patient has these non-adjustable risk factors like abdominal ascites, advanced malignancy, patient with alcohol abuse, anemia, diabetes, history of cardiovascular disease, smoking history, male sex, eye, ASA score, renal failure, and tumor size. These are the few non-adjustable risk factors. Can you prevent bowel anastomosis now? Can you prevent bowel leak after the anastomosis? These are the few modifiable risk factors we can think. Nutrition, steroids, good nutrition, stoppage of steroids, stopping smoking after 5 minutes, and timing of chemotherapy before the resection. That's also important. Another important factor is the mechanical bowel preparation. This is traditionally we have been preparing bowel with the oral antibiotics and various bowel cleaning agents, but nowadays the mechanical bowel preparation is again losing its sheen because of many studies showing that there is a patient dissatisfaction, electrolyte disbalance, and potential risk of posterior difficult infection. People are again going back just to the oral antibiotics and a simple decrease in fecal load rather than going for a full mechanical bowel preparation. That's also important part. Another important part is the hypotension. If the patient has a hypotension in the preoperative period, in the intraoperative period, the risk is very high. And if the patient receives some vasopressor, the risk increases by 3 to 4 folds. Another important thing is giving a fluid. How much fluid to give? Whether we should go with a over treatment or a under treatment. It's a big controversy. And nowadays the knowledge is shifting to our giving a less fluid. Similarly, the blood transfusion, it also increases the risk. Perioperative blood transfusion increases the risk by 10 times. The odds ratio is 10. And always aim for the restrictive transfusion. What about Ryle's tube? There is no significant reduction in the risk of leakage, but nearly 20% of the patient required exit tube in the early post-operative period. You have to think for the patient who were not opted for the Ryle's tube, 20% required again Ryle's tube. Drains. There is a old dictum: when in doubt, drain. That what we are taught nowadays it is impossible to drain the abdomen. That's the new dictum. So drains, it increases the incidence of anastomotic dehiscence. It does not improve outcome or reduce the complication with prophylactic drains, and in fact it may cause severe inflammation at the anastomose site. But drains are helpful when we are doing it, when we are doing surgery for the emergency operation, for a trauma or in a peritonitis or in a pelvis after an anterior dissection or coloanal anastomosis. So the great debate is for an anastomosis is whether we should go for a single or double layer, whether we should go for a continuous or interrupted suture, eversion or inversion of a suture, and what should be our choice of a suture material, and whether it should be a stable or a hand-sewn anastomosis. That's another debate. Basically, nowadays people prefer single layer because it uses less operative time, less narrowing of the intestinal lumen, there is a more rapid vascularization of the mucosal healing, there is a rapid increase in strength of the anastomosis within a few days, and there is an early return of normal bowel function compared with the double layer anastomosis. And what is the ideal suture? The ideal suture should have a minimal inflammation and tissue reaction, and it should provide a maximal restraint during the lag phase. That's the first phase of the wound healing. So monofilament or coated braided sutures are the most effective ones. Interrupted sutures are better than continuous ones because continuous sutures are associated with lower peri-anastomostic oxygen tension and less narrowing of the lumen. Sometimes we have a problem of a diameter issue. One end of the bowel is bigger and another is smaller. Then in a hand-sewn anastomosis we can give a oblique division of the ends, or we can cut back the end division to borders. Or we can go with a side-to-side anastomosis, or sometimes we may even temporarily intubate the bowel. People have applied fibrin glues and buttressing of the anastomosis in the esophagus is people have found in some studies is helpful and it has decreased anastomotically. Now, another important part is the staple. When the staple first arrived, it was around 3.6 kg and it took 2 hours to load. It was in 1908. These staples, they are made from a titanium clips, but sometimes they may have a nickel, and some people they may be allergic to the nickel. This issue is important. Suppose patient has an issue with some jewelries, you should try to elicit that issue. And those are not magnetic. We have four types of staplers: transverse anastomotic staplers. This is the simplest type. And we have a linear cutter, circular stapling device, which has revolutionized the lower rectal and esophageal anastomosis. Not only about the types of stapler, the size of the staple length is also important, because different tissues, they have a different thickness, and even a stomach, it has a very thickness from the cardiac up to the pylorus. You should think about the thickness. People have used, many surgeons who have used, I have seen many surgeons using suture reinforcement after a stable anastomosis. People use biabsorber suture lines. And this stapling is going to increase. In 2000 it was only a 100 million market. In 2015 it was a 3.4 billion market, and it's increasing with a rate of around 8%. And what are the advantages of doing stable anastomosis? It provokes minimal inflammatory response compared with the anxious anastomosis. It provides better support in the weakest phase of healing. It shortens the operating time. It has a lower recurrence rate at the stable line. So, what is a good anastomosis? And what good anastomosis requires? It requires adequate exposure and access. It requires a gentle handling of the bowel, a well vascularized bowel. There should be no tension, a good technique, and finally there should be no fecal contamination. The ideal anastomosis should have a zero leak rates, should promote early recovery and function. There should be no vascular compromise, not narrowing of the lumen of the lid. It should be easy to teach, and techniques should preferably be to perform. And surgeons are still searching for it, the ideal anastomosis. So finally, any anastomosis, no matter how technically sound on creation, may fall. Always think of this, and always think of diagnosing before closing the abdomen. Thank you, ladies and gentlemen, for your comment.
Hand over a certificate or